Brilliant Blue G has been shown to stain the internal limiting membrane very well and had no significant toxicity to the retina in rats, primates and human subjects. We have incorporated Brilliant Blue G into our surgical practice and routinely use Brilliant Blue G in macular surgery with good surgical and functional outcome. In this video, we shall be presenting the use of Brilliant Blue G in assisting internal limiting membrane peeling in idiopathic macular hole, epiretinal membrane removal, vitreomacular traction syndrome, macular hole retinal detachment, and recalcitrant diabetic macular edema. Our first case is of a 66-year-old female who had complaints of diminution of vision since 1 month. Retinal examination revealed a taut posterior hyaloid, and the optical coherence tomogram confirmed the presence of a vitreomacular traction which caused her symptoms. We performed a 23-gauge pars plana vitrectomy. A posterior vitreous detachment was created. Keeping in mind the plane of vitreomacular traction and taking care not to deroof the neurosensory retina at the site of abnormal adhesion. Once the area of vitreomacular traction was separated from the surrounding hyaloid, posterior vitreous detachment was induced in all the quadrants. After completing posterior vitrectomy, air was injected and Brilliant Blue G 0.05% was injected. After waiting for 1 minute, the fluid was restarted. Internal limiting membrane peeling was started away from the macula, away from the blood vessels, using a Grishaber's disposable internal limiting membrane peeling forceps. The attached vitreous was carefully separated at the fovea. After internal limiting membrane peeling, the retinal periphery is examined and a long-acting gas was injected as tamponade. 1 month post-operatively, there was restoration of the foveal contour with no traction on the fovea. Our second case is of a 61-year-old female who had diminution of vision due to a full thickness macular hole. She underwent 23-gauge pars plana vitrectomy with internal limiting membrane peeling and gas tamponade. After completing posterior vitrectomy and staining the internal limiting membrane with Brilliant Blue G, instead of a typical macular excess, the internal limiting membrane was peeled across the fovea to avoid its remnants along the margin of the hole. The internal limiting membrane was peeled at least up to the vascular arcades. Long-term gas tamponade was used. 1 month post-operatively, macular hole closure was noted. The third case in our series is of a 67-year-old male patient who was a known type 2 diabetic with persistent diabetic macular edema, post-intravitreal antivascular endothelial growth factor injection, and focal macular laser. The optical coherence tomography highlighted the presence of macular edema and an epiretinal membrane over the macula. After good posterior vitrectomy, Brilliant Blue G was injected to stain the internal limiting membrane. This facilitated the visualization of the epiretinal membrane due to negative staining. The stained internal limiting membrane could then be clearly seen. The internal limiting membrane peeling was started at the stained area to achieve complete removal of the epiretinal membrane. The epiretinal membrane was carefully removed to avoid deroofing of the edematous fovea. 1 month post-operatively, the optical coherence tomography demonstrated a resolution of macular edema. Peeling the internal limiting membrane helped prevent recurrence of the epiretinal membrane in such cases. This is a case of a 66-year-old female who had epiretinal membrane with macular edema as seen on the optical coherence tomography. Demonstrated here is the use of a double staining technique using Brilliant Blue G to confirm the internal limiting membrane peeling in a case of epiretinal membrane removal. Negative staining of the epiretinal membrane was easily appreciated as shown here. Epiretinal membrane removal was performed. brilliant blue G staining was done for the second time to ensure complete removal of the internal limiting membrane along with the epiretinal membrane. If any residual internal limiting membrane was seen at this stage, it could be easily removed. Post-operatively, the optical coherence tomography demonstrates restoration of the foveal contour with complete removal of the epiretinal membrane. Our last case is of a 52-year-old male who underwent pars plana vitrectomy with internal limiting membrane peeling and gas tamponade for a macular hole retinal detachment. Perfluorocarbon liquid, or PFCl, was used to prevent brilliant blue G entering the subretinal space through the macular hole. Brilliant blue G was injected after turning off the infusion cannula. After waiting for 1 minute, the dye was washed and internal limiting membrane staining was achieved. Perfluorocarbon liquid bubble provides counter traction while peeling the internal limiting membrane. The internal limiting membrane peeling can also be done without the use of perfluorocarbon liquid. Post-operatively, the retina was attached with no subretinal fluid and hole closure was achieved, as illustrated on the optical coherence tomography. We have demonstrated in our video the various scenarios in which brilliant blue G was successfully used to ensure internal limiting membrane removal and thereby achieve desirable post-operative outcomes.